We'll move on to our last speaker, Dr. Robert Lemery, electrophysiologist at Ottawa Heart Institute and Associate Professor of Medicine, University of Ottawa. And he'll be talking about ablation, this time for atrial fibrillation.
Thank you again, everyone, for being here and the invitation. The presentation that was given this morning by me earlier obviously had to discuss AF ablation, so I didn't want to repeat what we said this morning. So what I thought I would do, and because of the late hour and people, I sort of suspected we'd be around this time, people are hungry and so on, I'm going to review only three aspects related to AF ablation. I'll show just one slide that we showed this morning. We'll talk, where's the, here it is. So just a few introductory slides. AF ablation, we need to talk about the type of atrial fibrillation. Are we ablating paroxysmal AF or persistent AF? For those of you starting an AF ablation program, paroxysmal AF is simpler to do than persistent AF, and so paroxysmal AF with a good PVI procedure has a good chance of controlling AF. Sometimes a second procedure is needed, but a lot of patients are greatly ameliorated by their AF ablation procedure. Power sources, radiofrequency remains the main power source used. Cryoablation we'll talk about. Diode laser we'll talk about. I put in electroporation. Eugene this morning showed a slide of high energy DC with the Weber globe formation, and we and others worked on low energy DC, and now there's at least two groups working on low energy DC, ablation for atrial fibrillation, one group working in the OR with a device, and the other group actually working percutaneously with a circumferential catheter to produce this electroporation. So that's kind of interesting. Catheters and mapping, we have the irrigated catheter, the balloon catheter, and what's next, I just mentioned here, autonomics and epicardial considerations. So this is the slide I showed this morning. I think it's important to show in the sense that it, again, underscores the difficulty in doing this procedure because of collateral structures, including the phrenic, including the esophagus. We have to tiptoe around certain areas in terms of how much energy delivery. When doing the balloon cryo procedure, you have to determine where the phrenic is. And then when you ablate endocardially, because of ridges, structures, thickness of tissue, it remains a challenging procedure in order to isolate correctly different regions that have different anatomic structures. And therefore, the safety of the procedure is our first consideration doing this procedure, as our motto is safety first, success second. As you do this procedure, taking into account that you're treating atrial fibrillation, but major complications are rare to infrequent, but they occur, and when you add them all up, they're certainly there. So esophageal fistula is not going away. There's a recent report by a superb group showing that they did all the right things, and in spite of that, their patient ended up with a fistula 2 weeks later. They had an excellent program. They were able to operate on the patient, and the patient survived. And there's a report that's coming out in JCE that reviews this subject about the number of cases and its ongoing problems and potential ways to minimize the risk of esophageal injury. Cardiac tamponade, when it occurs in laboratories, can be a big issue in certain labs that are not used to doing the procedure and dealing with cardiac tamponade. Strokes remains an important issue, but because of the levels of heparinization that are used, appears to have decreased, and now the recent data that we have on doing procedures on warfarin, I think will possibly change the way we do the procedure. And so using intracardiac echocardiography, in some centers TE, but ideally a nice probe, doing the procedure on patients with a therapeutic INR, giving heparin during the procedure, and therefore not having to do necessarily a TE before the procedure, not having to switch to low molecular weight heparin, patients being able to be discharged with the therapeutic INRs, that may further reduce the risk of stroke. PV stenosis is thought to be, again, infrequent because our ablations are directed to the antrum more than to the osteo area, but with the advent of balloons, PV stenosis could be a concern. There's a report coming out in Heart Rhythm on the first case of severe PV stenosis with the PVAC system. And so we may anticipate that because of the osteal applications of the balloon catheters that indeed we may see perhaps more PV stenosis. Phrenic nerve we already referred to. Minor complications are infrequent, and obviously we want to try to minimize that as much as possible. And so what is the true success of AF ablation? Well, it's so wide, it's not funny. It depends on who you're talking to, what center, how the results are presented, and the experience of the lab, obviously, the type of patients. Is it paroxysmal? Is it persistent? Are we counting atypical atrial flutter after the procedure, atrial tachycardia, etc.? So there's a lot of aspects to consider. PV reconnection is one of the main problems related to the procedure, and gaps in the line of ablation is the other one. So balloon catheters are here. They're used at some centers more than others. We discussed this morning the STOP AF trial, and so suffice it to say that balloon catheters will be used by centers performing AF ablation. The technology is available. It's just a matter of time to see these balloons being used in the labs in the US, Canada, as well as in Europe and Asia and in this region. And so I think the crowd balloon is what we discussed this morning, the STOP AF. The HIFU has been removed because of the risk of injury and esophageal fistulas with it, at least 3 that were reported. Radio frequency, irrigated RF, there's a new balloon that was at least shown to some investigators, and we had a chance to see it in Berlin a few weeks ago at the AF Alliance meeting, but this is a circumferential catheter that is similar to perhaps in shape the PVAC catheter, but it's a circumferential catheter that has irrigation and that will record and deliver with irrigation in the ostial area of the pulmonary veins, and the diode laser. The diode laser, I wanted to show a few slides. We have done animal research on the diode laser. This is one of our slides in the animal lab. But the diode laser is interesting in the sense that you can see the ablation lesion because of the availability to see with the endoscope. And so a visual guided catheter ablation using light energy is what we're talking about. This was presented at the Heart Rhythm meeting last year, but the balloon is inflated in the pulmonary vein. You can shine the laser light in segments as you turn around. And so perhaps because of that, you may be able perhaps to direct the energy better, and you can then see through your endoscope the blanching and therefore the lesions delivered. So will that help perhaps as a means to know that you've successfully ablated? And in the animal specimens that have been studied, you can look at the circumferential nature. So the first patients were done. The project was stopped. We were back in Boston with experiments in June 2007. Then it went back in the fall and the winter to Prague with Vivek Reddy and the group in Prague. And so now we're seeing publications on the use of diode laser. Stereotaxis is used by perhaps 150, 140 centers in the world for AF ablation. So the appealing aspect of stereotaxis is that it's a soft catheter in the left atrium, and you can have an automated way of using it. With the announcement, I think, in the newspaper here yesterday of the and actually at the meeting, looking at the program and seeing the importance of robotics, I thought I'd mention a few words about stereotaxis and the announcement in the paper, I guess, of a big decision or agreement with Weill College about the use of robotics in surgery, but this is robotics for us. So we have a stereotaxis in our center. So the thing that's very appealing about stereotaxis is that it's a soft touch catheter. It applies 4 times less force than the conventional. Just recently, the 0.08 Tesla that's used during stereotaxis has been increased to 0.1, so we will see ablations that have a little bit more